Okay, so this presentation is actually going to be on um, the, I want to share computer audio. Oh, I hope you guys will be able to hear my videos. This is an updated program, so sometimes it gets a little wonky. Okay, so sure, I can do this as well. Okay. So we have a lot of issues with kids in care who have attachment issues. I'm sure you guys have encountered that. Um, hey Sharon, are you at a computer?
Yes, I'm on my computer. I just enlarged my screen.
No, you're fine. Can you mute your computer so that we don't hear if you have to take your call? Unless, do you know how to do that?
Well, it says mute, so I just press the mute button,
Yep, and
correct?
then when you have a question, you unmute it.
Oh, okay. I had to get me a pen. I'm sorry. I
No, you're
made too
fine.
much noise.
No, it's just very touchy. No, perfect. Thank you. And then if you have a question, pop it back on. Thank you so much. Okay. Yeah, so we have a lot of issues with kids in care who have attachment issues, which should be, I mean, fairly obvious to us, especially if we're, pulling them out of their homes, and putting them into different homes. But even prior to that, a lot of times they struggle to attach to their caregivers. And so by the time you guys get these kids in your home, um, they've already had broken attachments. And you guys are a lot of times seeing the aftermath of that. And that comes out in behaviors. And so I think that's why this training is important. We do touch on it initially if you guys go through the MAP trainings, the TIP MAPS training when you become a foster parent, but it really is something that needs to be revisited, and you guys need to have some information on how you guys can feel more confident in addressing it. So that's the purpose for this presentation. It'll be kind of full of information, and hopefully something in this presentation will be helpful for you guys. My name is Jennifer Danford. I have trained some of you before, I think. I am with KBC. All I do is foster parent training. I do the MAPS classes. I do these trainings to get you guys your hours. I do referrals for families who need a little extra help when it comes to training. And so I'm really interested in finding the kind of trainings that will help you guys and actually give you guys helpful information, not just the check off the box trainings, but you guys have a really difficult job. And so that's kind of my passion, is trying to find things that will help you be feel more fulfilled as foster parents, and also be able to hang on to the kids in your home a little bit longer if that's possible. So when it comes to attachment, um, we could like just go on forever and ever, but we're not going to do that tonight, obviously. There are some longer attachment classes. I'll talk about them later, but tonight I just want to make sure we go over some of the common attachment patterns, because I think once we identify some of those patterns, it helps us um, be more aware of where our kids are at, and gives us an idea of where we can maybe get more information, more research, and how to address them. There are some attachment diagnoses. I know you guys have probably heard, RAD and those things thrown around. Um, there are a couple different ones. I learned some things, even though I've been in this field for quite a while, um, that have helped me have some different language while I was coming up with this presentation. So hopefully this will help as well. And then obviously, whenever I do presentations, the things that are the most helpful for you guys are figuring out some interventions or supports that will help with all of this. So hopefully throughout this presentation, we can figure out some things that can be supportive for you guys, as I think attachment is one of the harder things to deal with when we have kids in our home. So attachment essentially is this ongoing relational process. We all do it. This is something that happens throughout life. However, it really focuses on the specific and vital developmental tasks that happen early in life with children. So a lot of times these tasks are either achieved or they're not because of this pattern of relationship between the parent and the caregiver and the child. And so that's going to be what the definition kind of is. So what we've learned, and I could give you a huge history, I just don't know that that's going to be the point of importance here, is that healthy attachments do create an atmosphere for better development. We see higher functioning, social competence, and success in adulthood. And if we think about that last sentence, we can kind of think about the polar opposites and think that's what happens when we don't have healthy attachments. And we'll talk about that more. But, not being competent socially, not having success, having lower functioning, those things can be the result of not attaching well. But even as adults, our attachment styles, they dictate how we engage and relate with the people who are important to us in our lives. Obviously, if we are married, our spouses, but also our friends, our family, our coworkers, our employers. This is all based on how we learn to attach as infants and young children. And so, if we're thinking about this in the foster kid terminology, these are things that happen prior to the kids moving into your home, and this is probably the time when most of the trauma occurred. So we're talking about some trauma, because if this attachment didn't happen, there was some trauma there. So what is that? That is a disruption in the development process of bonding. So, obviously we can look at it and think there's an overt abuse situation, physical or sexual abuse could cause attachment trauma. That's easy for us to understand, but neglect causes the same thing. It might be less obvious. I think to you guys, it's still obvious with all of your training in foster care, but a lack of affection or response from a caregiver can be just as damaging. And it can occur if there are traumatic experiences in the home, like domestic violence, if one of the caregivers is not in the home from divorce or being incarcerated, if one of the main caregivers becomes ill or dies. And so there are a lot of different reasons why attachment doesn't happen besides abuse as well. And so we know that our kids' trauma comes from a whole different bunch of different areas. And so it's important to remember this. So there are some common symptoms and behaviors of trauma that happens in attachment. And we'll talk more about these, but some of these are inability to give or receive affection, not trusting others is a big one, not being able to empathize with others. We see that in our kids and we get pretty scared, like they just can't understand that their friend is hurting because of something they did to them or their sibling. And then just outright destructive behaviors. So I think we start seeing those behaviors and we get kind of frightened, like, what do we do? Is it too late to do anything? What happens next? So here's where we start if things are good. Secure attachment. If things are good, we're attached, we have confident attachments to our parents or whoever cared for us. They don't question whether or not they're going to be cared for. They know they're going to be responded to unconditionally. these kind of kids have a good sense of trust, and you can see them extending this to other relationships in their lives. So they are the ones who, they like their teachers overall. They like their coaches. They don't assume that people in their lives are out to get them. They just have kind of a sense of security. So research tells us that 55% of the population has secure attachment. When I do give these figures, kids in foster care's figures are a little bit different, and sometimes I can tell you what that difference might be. So you might start out with a secure base. Our kids might be doing well, and then something happens in the home that changes that, and then their attachment style starts to be traumatized. Some of these things are the exact things that we see that bring our kids into care. Mental health conditions of the parents, social and economic stresses, maybe homelessness, substance abuse or use, family or domestic violence, even chronic illness. Some of these things may occur after the child is, born or a year or 2 years old, but they have not totally built their attachment yet. And so then that's jarring and their attachment starts to change. So there are different kinds of attachment that are insecure. And this is what we see in a lot of our foster kids. I would say we rarely see that secure attachment. A lot of times we see these kinds, avoidant, anxious, or ambivalent, or disorganized, disoriented. So all three of these are different insecure attachments. There are different outcomes that go with each of them. I think it's helpful to know which one maybe a child in your home may be having, because they show up differently and there's different interventions that could be helpful. So they can all be caused by those things I mentioned before, different things happening in the home, inconsistency in parenting, if the child feels rejected or neglected, or just an overarching sense of fear, which occurs a lot with abuse and neglect. So we'll talk about avoidant attachment first. Kids who have this avoidant attachment pattern have learned that when they have feelings and emotions, their main caregivers don't respond to that with empathy. They learned that if they do get upset or angry or sad, that this seems to upset their carer or their parent. So we have to attach to people. It is a biological process that keeps us safe, right? We're a child or a baby. We cannot take care of ourselves on our own. So in order to keep that attachment safe, kids with this avoidant attachment deny or repress their emotional needs. They would rather not have those outbursts or emotions and still have some sort of perceived attachment with their caregiver. So this is kind of falls into the flight strategy. If we talk about fight or flight or freeze, this is kind of a flight strategy. Out of the normal population, 23% of the population has this kind of pattern. If you see some of these things, it could be avoidant attachment. They aren't able to attach in any other relationship, really. If they have excessive independence, they don't ask for help. You find out they're doing awful in school, and you talk to them about it, and it turns out they've known the whole time and they never reached out to you. They never told you. That could be part of it. Isolation. They're the kind of kid who never tells you something is happening. They just go to their room. A lot of times there's eating disorders, self-harm, and depression that goes along with this avoidant attachment. So, okay, so anxious or ambivalent attachments, also an insecure attachment. This one is a tough one, because this kind of parent is inconsistent, and unreliable in meeting the child's needs. Okay, so maybe this parent is can provide safety and love one day, but the next day this parent has mental health issues or substance abuse issues, and so they cannot be present the next day. And so this can be very, very confusing for a child. So the child tries to change their behavior in order to get their needs met. They think it's them and not the parents. So they work extra hard and they will do anything, any means necessary. So they will get extra angry, exaggerated behaviors, threatening, clinging. We see a lot of these kids in foster care. They feel like the louder, the more anything they can be, the better their needs can be met. Because they're children, they don't understand that it's the adults' issues. So when they're successful, sometimes they reject the carer because of this push-pull pattern. And so this can be a really negative and tricky situation, where the kid gets the attention and then they're mad they got the attention, and it's just this drama, push-pull back and forth. I will say one thing about this anxious ambivalent attachment. We do see that kids who have this, when they grow up and become adults, often get into relationships that mimic this, right? So like we see teenagers in care find boyfriends that create this drama push-pull where they have to do big things to get attention from each other, and then they reject each other. It's kind of like this re-traumatization. So this is a fight strategy, obviously more loud. 8% of the population has this attachment pattern. But again, these insecure attachment patterns, our foster kids have a larger number of them. This is the normal population. So some of the presentation would be they overreact to hurt. So they're very sensitive to criticism. Lots of energy. They really struggle in regulating their emotion. All of their emotions are like straight to maximum level. We might see ADHD, might see a lot of anxiety and reassurance seeking. It's almost like they need an adult to regulate their behavior all the time because that's their reassurance of attachment. All right, so disorganized and disoriented attachment can be a really tricky one also. This is sometimes referred to as the most extreme style. There are a lot of outcomes that go with this one that are not the best outcomes, but we'll talk about how we can throw in some things that can maybe change the outcomes. Not everything is a definite outcome. So this is when the carer is the cause of their distress, as well as their only figure for resolving distress. So we see this in foster care a lot. So a mom might be the abuser. Maybe she physically abuses her kids, but she also comes to their aid and takes care of them and meets their needs. So how does a child begin to understand the safety in that? That is really, really, really hard. And we do have a lot of kids that would be the case for. So no matter what the child does in response to their own needs, they can't, there's no win answer here. It doesn't bring proximity, safety, and comfort. They can show emotions, but it may get them physically abused. They can hide their emotions and may get them physically abused. So there is no answer here for the child. And so that is really distressful for the child to know that nothing can provide safety for them. So kids who have this style of attachment can be bizarre in their way of relating to others because they don't know how to relate or regulate their emotions. They can be chaotic, confused, incoherent, and have angry ways of relating to others. Again, they have not learned a coping strategy, whether that strategy is maladaptive or any sort of adaptive strategy. Some of the other ones we talked about learned maladaptive coping strategies, but at least to them, it made sense. This kind of kid is just kind of lost. Research shows that that's 15% of our population. We'll see chaotic, fearful, angry, kids who kind of dissociate, they kind of step away, they might be in their own head, and maybe even have bizarre behaviors. So here's kind of just a little map of what these look like. On the high anxiety end, we have the disorganized and the anxious avoidant. And then on the low anxiety and low avoidance, we have, secure. So there's just different presentations here about how it may look. And again, everything's kind of on a spectrum. You could have someone who's disorganized, but not, all the way to the top. I think all of us fall into these categories as well. Not everybody's secure. And so it's good to know where you are as well. So that might be something you could look at. This is kind of a quick, I think it's a 3 or 4 minute video about these kind of different bases. And I think it's helpful to move us into the next part of the presentation. I hope you can hear it.
Young children use their attachment figure as a secure base for exploring and coming to understand the world. When they feel safe, they will venture out and explore the physical world and explore the social world. That sense of felt safety is a crucial aspect to feel good about moving out into the world. So building attachment is a matter of building connection. And that programming makes us resilient, sensitive to other people's needs, sensitive to our own needs, and a healthy, well-functioning human being. In secure individuals, we see that rich set of connections. When we talk about attachment, we're talking about the dance between a parent and a child. How well we're able to dance together will determine how well they're able to dance with other people later in life. We also know that my ability to dance with my child is determined by my past to a large extent. But we know that infants who become securely attached have parents sensitive to their needs. But here's the key thing. If they're separated, secure babies look distressed, but the avoidant babies did not look distressed. So they learn to mask this internal state of fear and anxiety. And that's the origins of the avoidant adult's experience. A person may do fine in situations that don't demand interpersonal connection, but when they demand that interpersonal connection, they begin to flounder. An ambivalent baby looks like a secure baby. They can be hard to distinguish. Both babies are distressed when the attachment figure leaves. The difference is what happens once they actually reunite. An anxious ambivalent baby, they want to be reunited, but once they're picked up, they may push away a little bit, or they may be stiff, or they may kick their feet. We know from research that parents of anxious ambivalent infants have only been available inconsistently. There's a fourth classification, and that's called disorganized. A disorganized baby has no clear pattern to the way they respond. The person who should be providing them security is a source of pain and hurt, and that shows up in their behavior. When attachment is derailed, we have kids who look angry, can't regulate their emotions. In TBRI, we talk about principles. Well, the connecting principles are designed to promote the kind of relationship that leads to secure attachment. And the engagement principles especially make a difference for children who come from hard places. So it's structure and nurture. But the good news is there's the hope that comes from knowing that this can be done. And the path is awareness. The path is mindfulness.
Okay, yeah. I'll talk briefly about TBRI later. But when we have these insecure attachments, especially when they're kids who've been exposed to trauma, neglect, or abuse, sometimes these attachments can be so significant that they do turn into attachment disorders. So not every insecure attachment is an attachment disorder. I think for a while we were hearing a whole lot of, RAD, reactive attachment disorder. I do think a lot of our kids have some attachment disorders, but I don't think it's every kid. I think a lot of our kids just have attachment stuff. But there are two trauma-related disorders in the DSM, which is, where our therapists and clinicians actually do diagnosing that are linked to attachment behaviors and patterns of interaction with caregivers. So this is kind of just a slide on reactive attachment issues before we get into the actual disorder. But reactive attachment issues can be caused by abuse, neglect, and abandonment early in life. Really what's important here is that a lot of this stuff can range across the spectrum of attachment development and needs. A lot of these kids fall somewhere on this spectrum of needs. Everyone, every human, every child has a craving for belonging and love. It's necessary, like I said, it's a biological necessity because we cannot survive alone as children. We have to attach. And so even though they may have some of these issues, we still need to figure out how we can help them. Reactive attachment really came from a lot of research that started with kids who were actually in orphanages, like in other countries, Russian orphanages, kids who had no attachment figures at all. And we started seeing the same symptoms here in the United States with kids who were in care or kids who just didn't attach. So reactive attachment disorder is one of those diagnoses. I think we do see some of these kids in care, but keep in mind there's a second disorder, and I think a lot of our kids may fall into that second disorder. So reactive attachment disorder, commonly referred to as RAD, affects a lot of kids in foster care or kids who are adopted, even as older kids. Again, usually found in kids who were severely neglected, which could be a lot of our kids. But this prevents them from forming healthy, loving bonds with their caregivers before age 5. So their emotional needs weren't being met. So they just don't have that understanding of how to respond, specifically socially, also within a family unit. So they don't understand how to respond to love and affection of new caregivers or trusted adults. So I think it would be pretty rare to have a case of RAD in the same family unit that the child was born in. But it would be much more common to have RAD with a child who was placed into a different family, fostered, adopted, something like that. Even if it was a kinship placement or relative placement, it would make sense. So here's some prevalence on RAD. It is unknown because of diagnoses and trying to figure out how often. It can happen in 1 to 2% of kids, but it shoots up to much higher when we're looking at foster kids. I think even like 15 or 20% of kids in care have RAD. So there is a huge difference between the regular population and kids in care. So some of the signs and symptoms of reactive attachment, and some of these are for younger kids, and some of them might be for a little bit older kids, but failure to smile, looking sad, listless. They won't reach out when they're being picked up. They don't want to ask for help or assistance. Lots of withdrawal, irritability, sadness, fear. They are not comfort seeking. They do not show response when comfort is offered. They do watch others closely, but will not engage in social interaction. And then they have lack of interest, even playing peekaboo or other interactive games. So, you know, if you saw these symptoms in a child, it would be highly alarming to you, and overwhelming for sure. Older kids with RAD might have symptoms like anger, violent outbursts, subversive responses to command or directions, like they're not going to listen. And then their relationships with others that they form would be not typical or maybe even inappropriate. So I'll talk about some treatment later, but it's pretty clear when someone's attachment disorder is severe, because this happens 100% of the time. They don't magically change into kids who can attach for an evening at dinner and then they change into this. This is pretty much all of the time. In older kids, this is interesting. They might have hypervigilance, contradictory responses. Instead of just being combative, though, they might find ways to work the system. So we see this in older kids. So they might mishear your directions, or maybe they might take your directions exactly to heart instead of taking them as they were being presented. So complete tasks in unexpected and sometimes more time-consuming or counterproductive ways. So really just being difficult on purpose. So I'll talk about assessments too, because it's not up to you guys to try to figure out all of this. Although finding assessments could be difficult, it's important that we do this. So this is the other one, disinhibited social engagement disorder. I'm going to be honest, I've been in this field for 20 years and I didn't know much about this one, but I think as I researched it, I think we have a lot of kids who do fall into this more than maybe RAD. So this one is an attachment condition characterized with they struggle with forming emotional bonds with others, but they also have this lack of inhibition around strangers. So lots of times it happens in our young kids who have had neglect, trauma, abandonment, or abuse. That's pretty much all of our kids. It's thought to be fairly rare, but kids who have been raised in institutions or have had multiple foster care placements are at highest risk. A lot of kids with a history of abuse don't develop attachment disorders, but studies suggest that around 20% of kids who do have these backgrounds develop this disorder specifically. So that's a fairly high number. What is that? 1 in 5, I think. 1 in 5 kids has something like this. And I do see this with a lot of kids. Some of the signs and symptoms. Excessively familiar physical and verbal behavior towards unfamiliar adults. You know, like your kid, you've talked to them 100 times, but they still want to go show toys to strangers at Walmart or at the park or whatever. They don't check in with their parents or caregivers. They have poor social boundaries. Again, that inhibition around strangers is minimal. They'll go with strangers with little or no hesitation. There's also 3 other big signs: no preference for caregivers. So, you know, our kids like who are securely attached, if one of them was to fall and hurt themselves, usually they'd run to the same parent. Like they're going to go to mom every time. But if a kid with this disorder falls, they might even not run to their caregiver. They may run to someone else at the park and say, I've hurt my knee. So they don't have this allegiance or preference for caregivers. They don't know who's trustworthy. Research using imaging has actually shown that they cannot discriminate between like looks on faces. So, you know, they showed faces that looked mean and untrustworthy, and then they showed ones that looked kind, and they had no understanding of the difference, which puts them at significant risk when it comes to making friends. Our older youth, you know, when they come home and they say like, I'm going to so and so's house, and you're like, who? And they're like, you know, so and so I met at the gas station. They're like my best friend now. You know, those kind of kids. You don't even know how old that person is. And then they crave kindness since they can't identify a safe person. They're showing affection towards anyone who might give them like a morsel of attention. So it could be someone who's unsafe. So, you know, it could be a teacher that they don't have a class with, that they are, you know, really trying to get their attention. They're trading Pokemon cards with that person or something. This is the child that can be clingy also, because you were a stranger to them at one point if you were a foster parent. So this is the child that shows more clinginess, really struggles with social boundaries. So other disorders that are connected to attachment, anxiety, depressive, dissociative, borderline personality disorder. That's usually you know, teenagers, but that is tied hand in hand with that that last attachment style I talked about, the disorganized attachment, oppositional defiant conduct, antisocial, eating disorders, and then substance use disorders. So we know trauma and attachment are connected, because traumatic events can cause attachment issues. We talked about some of those. But also having traumatic events occur can complicate symptoms of attachment or make some of those symptoms even worse. Most of that stuff happens before they come into your homes, but sometimes those things happen later, like if visits with family is not going well, or if they are going well, or if court cases change, you can see how this would bring up attachment issues and make them more difficult. So, quick review of trauma. Trauma is really any emotional response to an event that there's threatened or cause of harm. The event itself can be physical, emotional, real, or perceived. And then we know that it can be a one-time event, or it can happen multiple times, multiple events over time. Like our kids typically have, you know, neglect over time, or physical abuse that happens more than once. We have a lot of trauma sources. This stuff happens to our kids as well as their parents, but we know removal from home and moving placements is a source of trauma, but we know that it's also the initial neglect and abuse. Often there's poverty, home or community violence, community crimes, but even things like auto accidents, loss of significant others, having someone in the home with a medical or a psychiatric condition, or even natural disasters can be part of trauma. We know our kids have PTSD, both diagnosed and just symptoms. The actual diagnosis of PTSD requires that they re-experience or re-remember some of the symptoms. Avoidance, they try to avoid those distressing memories. Negative cognitions and mood, so feeling alienated, having persistent negative beliefs, and then some sort of alteration in arousal, so reckless behavior or sleep problems, which a lot of our kids do have. I think you guys probably are fairly aware of what trauma looks like in our kids. But younger kids can't pay attention, they're quiet, withdrawn, cry a lot, talk about scary ideas or feelings, they can't transition, they fight, their school performance gets worse, they want to be left alone, eating issues, sleeping issues, a lot of somatic stuff like headaches, stomach aches, and sometimes their behavior regresses. And then in our teens, either they talk about it a lot or they deny that it happened when it comes to the traumatic event. They will act out like they don't follow rules, they talk back, they'll have sleeping issues, they might engage in risky behaviors, they might fight, they might isolate, use drugs or alcohol, leave home, or getting into trouble with the law. So this is where things with attachment and trauma kind of get together. There are different kinds of stress. Obviously, positive is what we all have. You're getting ready to go to work on a hard day, you're feeling stressed. That's a positive kind of stress. Resolves quickly. Tolerable. These are hard things. Someone in our family dies. We're getting through that grief. It's hard, but we know how to mitigate it through our support system. But toxic, this is what our kids have. This sort of abuse or neglect, and they don't have the support. Otherwise, they wouldn't have been taken from their homes. This kind of stress really puts a strain on their stress response system in their body, damages parts of their body and brains, because they're supposed to be developing. Instead, they have this adrenaline and cortisol running through their body, and it keeps them from developing appropriately. It can affect the nervous, endocrine, and immune system. I do a lot of trainings on trauma, so there's a lot more to it, but it does affect how they see the world, and it affects how they are able to interact with other people, which is our trauma. So complex trauma, this is the multiple trauma kind of scenario when a child or person is exposed to multiple and chronic traumatic experiences. And these experiences have a profound effect on almost every aspect of a child's functioning. A lot of times this kind of situation happens in childhood, and these traumas are caused by the adult caregivers who take care of these kids. So just a quick blip on adverse experiences as well, because this also feeds into it. If you don't know about adverse experiences, it's called ACEs. I'm just going to quickly go through it, but essentially it's a way of tracking trauma. It's a way of quantifying what kind of traumas our kids have, or any kids have, or even you guys. So it's, yeah, we can figure out what kind of physical, sexual, emotional abuse happened early in life that can cause attachment ruptures and secure-based distortions. And then these experiences can create a long-term pattern of seeking out harmful and volatile relationships. So we can see that kind of reenactment of trauma. So ACEs, like I said, are traumatic experiences, and the outcomes that go along with these are pretty negative. They're called ACEs. I don't want to say something and then it pops up on another slide. Yeah, so essentially what happened is the CDC and Kaiser Permanente did a study back in the 90s. They surveyed 17,000 adults about childhood experiences, and then they also asked them about things that were occurring in their life today, like health issues, mental health issues, job issues, those kind of things. And they were able to make some correlations between the trauma and those kind of things. So I will, okay, so the experiences include, there was 10 different ACEs, 10 different traumas. So they are emotional, physical, and sexual abuse, neglect, parental separation, substance abuse, incarceration, violence, and mental illness. Those are the 10. I can give you some resources if you're interested in looking further. But they did identify a link between those traumas, those ACE exposures, and a higher likelihood of negative health and behavioral outcomes later in life. It's really a questionnaire. This is the questionnaire. Each question is a trauma. I won't go through all of them, but For example, the question 1 is, did a parent or other adult in the household often swear at you, insult you, put you down, or humiliate you? And if the answer to that is yes, you give yourself a point. And so you go through the 10 questions that each correspond with a trauma, and you give yourself a point for each one that you did have that trauma. And so then you would end up with however many points out of 10. So maybe 1, maybe 4, maybe 6. And those points correspond with possible outcomes. And so some of these outcomes are that we know ACEs are common. We know 60%, 61% of adults reported that they had at least one ACE. And typically the ACEs are events that happen before the age of 18. And so 1 in 6 adults said they had 4 or more ACEs. We know that ACEs are linked to many health conditions. So preventing trauma could reduce that. They are linked to heart disease and depression, which costs, us a lot of money and people a lot of heartache. Some kids are at greater risk than others. Obviously, as with lots of things, women, racial, ethnic minority groups are at greater risk. And then it costs a lot. Economic and social cost of families, communities, and society is up in the billions of dollars each year. This is because of all the money that goes to taking care of these people who have, COPD, depression, mental health issues, who can't work because of all these outcomes that go along with trauma. So we know that it links it to chronic diseases, behavioral challenges, obesity. It is like dose dependent. So the greater the number, the greater the risk of negative outcomes. And there's actually a threshold of 4. So once you reach 4 ACEs, it's like, then you're in this whole new category of outcomes. 5 of the leading causes of death are associated with ACEs: respiratory and heart disease, cancer, and suicide. I have numbers on what our Kansas kids look like and the kids coming into care. So if you're interested, I do some ACEs presentations every now and then. It's really interesting to see what our kids came into care for. 30% of kids have experienced 1, 14%, 2 or more. The most common ones, and this is not for foster kids, just in general, are divorce and poverty. 51% of kids in care, however, have 4 or more. So that threshold compared to 13% of their peers. Also interesting that 20% of our foster parents have 4 or more compared to 12.5% of their peers. So you guys also have a higher rate of ACEs, which I think is true for anyone in the helping profession. I think we see larger amounts of trauma, but being aware of that is helpful. So kind of moving into attachment and alternate caregivers. So kids can have multiple attachments, even though typically they have a preference of who they may go to when they feel distressed or something happens. But being aware of that, of who those people may be, can help us understand their patterns. It's important to know that even if a kid was not able to form that secure base, we can help them form secure attachments. We can do this by providing safe, nurturing relationships while we're being a secondary caregiver. But when it comes to our kids, sometimes we need more, and I'll talk about that. Like, we need some therapy, we need some professionals, because it's not just a case of insecure attachment, there's trauma involved as well. Okay, so doing assessments is important to find out if they have these like actual diagnoses, because if they do, they need intervention. Finding out who does these assessments can be tricky in your areas. I think some of the community health centers do them, But sometimes you will have to kind of get with your agency and be that squeaky wheel to find out if there's an attachment center or therapists who do attachment assessments. But here are some things they might need, and you could go ahead and start collecting some of this information before any of that started. So you're going to collect information about a child to help a qualified individual make some diagnostic impressions. A lot of times they're going to want basic information, history of out-of-home placements, and it takes time to get this information because it can be like pulling teeth sometimes at certain agencies, at all agencies really. And so that's why you could even start working on it before you have identified a provider. Even losses or deaths the child has experienced, if they have any chronic pain, physical and emotional condition of birth parents, again, that might be tricky for you to try to figure out. Any sort of developmental history, medical history, if they've had other therapy attempts or copies of previous assessment results. I know these are things that the caseworker might have more, might be more able to get a hold of. But sometimes it's hard, again, trying to track that information down as well. So knowing that this is the stuff they need could help you get ahead of things. They also are going to want some information on you guys, and that's because their current attachment is you guys. So knowing that isn't, anything weird or out of the norm. It's just something to help with the assessment is good. So the other part is they're going to do observations, and that's because they want a good assessment would have observations to make sure they can kind of see some things in the kids. And some of this you could also be observing and taking notes and make sure the provider has. So how the child seeks and uses support. Does the child ever ask for help, or do they just get frustrated and quit something and then blame someone, or do they are they very independent? Like, what does that look like? Do they only ask one person? How both of you guys together balance ways to complete tasks while also trying to, keep the home a fun place to live in. How comfortable they are with the main caregivers. And I can also send you guys copies of this presentation as well. How the child caregivers share affection, like what is their preference there? Like, are they overly clingy and need 17 hugs every hour? Or are they not an affectionate child at all? How they cooperate, are they able to cooperate with their siblings? Or is it like their way and then it's just a big fight and then the game is over? How they manage conflict, and then how they respond to separation and reunification. How do they do when you drop them off at school or at daycare and then pick them up? There are some red flags of attachment, and this is with really young kids, infants. And if these happen, you really need to let the doctor or let the case team know immediately. If an infant has no stranger anxiety past the 10-month age mark, if they have no interest in interacting with caregivers, they don't smile or respond, they don't track objects with our eyes, and they avoid eye contact with other people, there's definitely something going on, and so that would be a high priority case. So these are the formal assessments that will likely be done, one of these. The infant and toddler ones are the Ainsworth Secure Base Behavior Scales and Attachment Q Set. So you could even ask and say, what kind of formal assessment will be going on with, the child in my home? The adolescent and adult assessments, Ainsworth Maternal Sensitivity Scale, Inventory of Parent and Peer Attachment, Adult Attachment Inventory, or Bartholomew's Attachment Interview and Self-Report Measure. Sometimes they'll do these and throw in some other sort of assessments, or they'll do a combination, but it can be helpful to know they're actually doing a formal assessment that can get you some answers. So here's some challenges. If the child's in foster care, you may not have access to the history. You cannot give them background information. And then another challenge is that RAD and even other attachment disorders can be confused with other problems and disorders, but also they can occur at the same time as these other disorders. So it's hard to tease out what's really happening. So autism, developmental disorders, and sometimes some other genetic disorders. And so that's why you need to really find a place that has a good understanding. And it might take several different assessments before you get some answers. And I do think it's important to get diagnoses because that can help inform treatment. Okay. Okay, so here's some things that we don't want to do with kids with attachment. It can be really scary when we get a kid in our home and we see that they're different than all the other kids, especially if we're experienced foster parents or even if we're new. But we don't want to assume that these kids are destined to have bad outcomes, like be predators or psychopaths or even be victims because they struggle with attachment. There are things we can do to prevent that. This one's really tricky, and it sounds like a judgment on foster parents, and it's not. It's just something. Don't portray children as having adult attentions, such as calling their behavior, manipulative, cunning, or deceitful. This is, like with, younger kids. I know our teenagers can certainly be manipulative, cunning, and deceitful. But understanding that these negative behaviors are behaviors developed from survival and fear-based instincts helps to kind of weigh that in a different way. Yeah, that one's kind of tricky. So also, when it comes to treatment, we don't need to assume that they have to be pushed to relive or revisit those traumatic experiences. But if they are doing that with their therapist, we should understand that they will be unhappy or upset with the therapist or anyone who has them do that. They will not like it. So if they hate their therapist and that's the work they're doing, we have to understand that makes sense. Yeah, don't assume that all behavioral issues observed in treatments surrounding a child's attachment issues imply that they have RAD. Just because they're being treated for attachment doesn't mean that they have a diagnosis. A lot of our kids have attachment issues that are significant but may not rise to that level. So this is interesting. Again, I like Karen Purvis. She's with TBRI, which is trust-based interactional. You know what? I don't know. Now that I'm saying it, it is a really good program on how to deal with really hard kids. Sometimes when she speaks, you feel a little bit like she's a little Pollyanna-esque, but I think her theories and what she's talking about is sound. And so this is a quick video on some of the behaviors.
Primary tools for children who didn't have a voice are manipulation and control. Now, all children explore manipulation, even in the most loving homes. All children explore control in even the most loving homes. Again, this is a normal developmental exploration. For the child from the hard place, manipulation may have become the way they believe they survived. Control may be what they believe stood between them and death. Now, when we look at a child with these issues, obviously those issues are not okay. But again, I don't want to overreact. I don't want to label my child a controller or a manipulator. I want to stand back from the behavior and realize it has a function. So if a child is saying something to me, for example, they want something, but they're using a manipulative round to get there, I will say, well, stop, sweetie. Now I'm going to be matching. I'm going to be looking into their eyes, and I'm going to say, now, whoa, stop. I want to meet your need, but I need honest words, not this little roundabout. Okay, so give me honest words. Let me see what we can do. Let's work it out together. And very often I will find a child say, well, I really want X. Now, if it's in my power at that moment, I'm going to say yes, because I want my child to know they don't have to use tricks to be heard by me. Now, I can't always say yes, obviously. I shouldn't always say yes, but I can say it a lot more often than I do. So we know from child development that there's a continuum of two poles that predict the best development long term: predictability and control. So some of our children have come from very unpredictable environments. Some of them have come from very controlling environments. But appropriate levels of predictability and control will help our children let go of the need to control the world. We have mothers who come to us saying, my child tells me what shoes to wear in the morning. So I say to that child, you know what? It's not okay for you to tell mommy what to wear, but let's go to your room and choose what you wear tomorrow. So I'm going to take away control of the world by giving my child appropriate control. Every one of our children must have appropriate control in their environment, and they must be able to predict what's going to happen. So I can take away these tools by giving, I can take away manipulation and control by giving my child appropriate levels of predictability and control in their environment. I can become their partner. Again, it's very important to come alongside of the child. It's not like, aha, gotcha, being bad, but rather, sweetie, let's work on this together. That's not okay. I'm listening to you. Tell me what you need. So one of the primary mistakes that parents make about this is thinking, my child is so controlling, I'm going to take away control of everything. And see, they're going to learn to make good choices by making small choices. I remember one darling little girl we worked with who had to be in control of everything, and she was just a tiny little bitty snippet of a thing. She was like 5 years old. But her mother was there, and I was there with her in the home, and her mother said, sweetie, we're going to have a peanut butter sandwich for lunch. Come on to the table. And she said, no, I have a better idea. Let's have a peanut butter sandwich for lunch. The little thing just had to feel like she was in control. And so we got down at her height and we looked her in the eye and said, no, Mama already decided on the sandwich, but you could decide between these 3 fruits for our dessert. What do you choose? So see, I'm going to let a child have some control. I'm sharing power. They're going to practice making choices in a controlled environment so that they don't have to take over the world. I have had a child come, for example, to our camp who was hungry many, many times. He would come into the camp door every morning asking exactly what we would have to eat all day long. And I went through what we would have for the morning snack and what we would have for the noon snack and what we would have all day long. And I did that with him for a number of days, more than a week. Every day I went through. And one morning he came in and I said, sweetheart, today, would you go with me and look in the kitchen and let me show you? We have so very much food. And I promise you, you're never going to be hungry here. But just for today, would you trust Miss Karen? I'm going to meet every hunger need you have. And you just get to be a little boy today. So for that little period of time, that little boy could practice trusting me just that long, just a few hours, that there was plenty to eat. Our children learn to make good choices as they trust that they have a voice, and as they trust that we see what they need. And in that environment, they will give up control and manipulation in terms of relationship.
Manipulation and control are issues that really challenge a lot of parents. I know they do me and my wife. When my kids are exhibiting manipulative and controlling behaviors, I often take that as a personal offense. I take it as a challenge to my authority. I take it as a challenge to my role as dad. And while manipulation and control are not okay, and when they're exhibited by our kids, I can't allow all of the emotions and the reactions that I feel to get in the way of looking deeper, below the surface of that manipulation and control, to see what's really going on. What is it that my kids are trying to tell me? What is it that they really need? The truth is that manipulation and control by our kids is often really just their way of inappropriately expressing a need. And if I can get past the personal affront and the personal offense that manipulation and control represents for me, and get to the heart of that need, help them understand that I'm here to meet that need, to help them meet that need, and more importantly, to help them appropriately express that need, then oftentimes what we can do is we can deal with the manipulation and control, not by coming down heavy and hard on it, but rather becoming more connected so that we can help our kids understand that we're their advocate, we're their coach, and we can help them both identify, articulate, and meet the deep needs that they have.
Okay. So treatment for kids who have attachment issues, or attachment diagnoses. We should try to ensure that they use evidence-based approaches, that address the behaviors and the presenting problems. 10, 15 years ago, they started having lots of different attachment treatments that weren't evidence-based. And some of these things were having our kids have even worse behaviors. They were, regressing the kids back to the womb and doing some crazy stuff. Make sure that you're having them be in an evidence-based program. They should involve either the birth parents or the caregivers. You cannot treat attachment with a child by themselves. Attachment inherently includes several people. So ask the therapist or the mental health center about that and what that looks like. That may mean that they work with a child alone for a month of sessions or something, and then bring some people in. But there has to be some sort of attachment they're working on. And then there needs to be a plan, focused, goal-directed behavioral intervention. And so make sure that's happening. It's not just showing up for therapy every week, because that can be really frustrating when you're not seeing results or not seeing anything happen, and you have connected with this attachment program or whatever. Again, it should be sound theoretically. So those are things you can ask. So just a couple things about mindset. Again, I think they touched on some of this, but traumatized kids who are not attached initially don't have a capability of trust. So knowing that it will take time for them to develop that trusting relationship with a therapist. Again, we talked about this earlier too, but some of these kids build exaggerated rapport with adults. So like they act like they've connected with someone really well, especially if they're a stranger or a teacher or an authority figure. So you should make sure that this therapist knows what they're doing, and doesn't rely on that presentation to assume that trust is there and they can work on things. I know a lot of foster parents who get frustrated with therapists because they feel like the therapist doesn't have a good picture of what's going on. And so making sure that you feel comfortable with that. Trust and rapport are built through honest validation of the trauma history and the current behavior issues. So they need to know those things. And then the clinician and caregivers are leaders for the session. So, the child does not lead the session, but the session should be safe, nurturing, and empathetic. A lot of times these kids are awkward around parents and caregivers and have a low tolerance for being left alone. They can seem inauthentic. Sometimes they don't put very much effort into their important relationships, but then they give a lot of effort into engaging with strangers. Again, they struggle with that emotional instability, but I think more importantly, they have behaviors that are resistant to traditional discipline methods. So those are the kind of kids I hear like, We've tried everything. Consequences do not work. So there's a couple different treatments that can be helpful along with a specialized attachment treatment. But child-parent psychotherapy, it's an intervention with the child and birth parent. If it's a case that's headed towards adoption or something, you would sit in on that. But it provides guidance and coaching, and there's goals that are set to support and strengthen that relationship. There's one called attachment and biobehavioral catch-up. This is a home-based intervention, so actually in the home, again, there's education and coaching. And then there is targets involved, which is nurturance, following the child's lead, reducing frightening caregiver behavior, and then also helping the parent overcome some of their stuff. Circle of Security teaches caregivers attachment theory, so it's educational. And then it helps caregivers become aware of their own responses when our kids are struggling. And then PCIT, which is Parent-Child Interaction Therapy. This is a really good one. Some of the bigger places have this. I know Kansas City does, maybe Wichita. But it's essentially real-time therapy where a therapist would work with you to interact and deal with the issues that are happening at that time. So that might be a good one to look into as well. And then ARC, which is attachment, self-regulation, and competency. So this is actually something for kids that builds on domains and skills. This is kind of what it would look like. There's trauma experience integration, but there's some skills and domains here that kids would work on. I like therapies and interventions like these because they have goals and structure, and it's not a child going and sitting with a therapist each week and talking about whatever happened that week, because we don't see a lot of progress with therapies like that. If they are specific to what's happening, we can start to see some progress, which is what you guys want to see. Some parental skills, knowing that you just have to build the relationship from the ground up. You have to start from scratch when it comes to attachment. Creating safety, you guys probably do that. Having positive interactions as often as possible, even when the child's been struggling. You're teaching about relationships, so modeling those, focusing on behaviors you want to encourage, focusing on teaching appropriate social interaction, and helping teach cause and effect thinking can be very helpful. Like I said, a lot of those insecure attachments, the kids thought, if I do this, then my mom will, attach to me better, and that was faulty. So helping them learn cause and effect teaching can help. So providing a few clear rules with clear consequences, and then using restitution as opposed to handing out punishments. So this is a rule for sure. If you don't follow this rule, then this is the consequence. And that actually builds connections in their brain and teaches this cause and effect thinking. And that helps with some attachment stuff. I'm not going to play this video. We're running short on time, but trust-based relational intervention is TBRI. We offer these trainings on Child Ally. They are more time intensive. It's usually 3 hours, 3 times a month, I think. And it really does help. It helps us learn to regulate these kids until they can regulate themselves. It takes a lot of time and energy, but it works. So if you're really struggling, you can look into that. I do have some resources, but I have to pop out here and then I'll show you real quick. And then we'll be done. Let's see. Okay, so here is a website called Attach. Here's some books. And this is on my references. I can send out my PowerPoint again, that are good. This is the TBRI. So it talks about what it is. You can watch the TBRI video here. And then this is Kalo or Kalo, I don't know how you say it. This is a program in Missouri that is just an attachment center. It's very expensive, hard to get your kid in, but they do have a lot of resources. I mean, they specifically only work with attachment. They do inpatient, outpatient, but they have some resources here. So those are good, and I'm glad to share those with you. And then that's it. The rest of my presentation is just references. So I'm glad to email you my PowerPoint if that would be helpful. But other than that,